Welcome to the Barrier Breakdown, Disrupting Mental Health podcast, where we talk about the clinical and practical issues that face those working in the mental health industry.
Hello, everyone, and thank you for joining us for this week's episode of the Barrier Breakdown. My name is Erin Molyneux-Bailey. I'm the Chief Operating Officer at Cognitive Behavior Institute, and my co-host, Dr. Kevin Caridad, who is the CEO and owner at Cognitive Behavior Institute. This week with us, we're very excited to be joined by Steve Oneill, who is the Open Notes Specialist in Behavioral and Mental Health and is faculty at the Center of Bioethics at Harvard Medical School. Steve is also an adjunct assistant professor at Simmons University and a social work consultant at the Massachusetts Medical Benevolent Society in Waltham. He is especially interested in how the transparency of open note writing in behavioral health can foster great trust and partnership, improve patient engagement, and contribute to destigmatizing mental illness and behavioral health. So thank you so much for being here with us, Steve. Our listeners are very excited to hear today with everything you're going to share with us. And could we begin by talking about how you got involved? We know you have quite an extensive background in social work ethics. So can you tell us how you got involved in this area of social work?
Sure, glad to. So my role at Beth Israel Deaconess Medical Center, which is where I'm based still, is I was overseeing all the mental health and behavioral health practices for the hospital. So that was one role. I had a role in that in terms of both as a practitioner myself, but also overseeing most of the therapy services, inpatient and outpatient. And then I also was associate director of ethics there. And did ethics and got started in open notes really back in the 80s when Dr. Lachlan Farrow and I started our ethics service at the hospital. We made it as a policy at the hospital that we would by policy, we would make all of our notes, our consultation notes, immediately available to the source patient and all of their immediate family or loved ones, whoever was involved in the consultation. And those are usually highly fractious, intractable conflicts that we are dealing with. And we found that really in sharing notes directly with these patients and families, that it really mitigated a lot of the risk and cut down on a lot of the legal noise, if you will, at the hospital. And our hospital had been we started at Beth Israel, they started the very first electronic medical record in the world was started there back in 1985. We went online. So we've had a long history. We started putting mental health notes when I felt secure enough back in 91. We started putting all of our notes online right in the middle of, all of they're not segregated in a different area. They're all a part of the patient's medical record. And patients, we began to, myself and several of the other staff, the clinicians, the therapists, we started saying to patients, if you ever want to see what's written in your chart, what I've written about you, glad to show that to you at any time. And I was worried, particularly all my paranoid patients would flee. And in fact, I found in particularly just the opposite. So we had started doing this transparency notion at the hospital. And then back 11 years ago, the hospital began the very first pilot in primary care medicine, where they began to share notes, open notes with patients through a secure portal. We began to share them. And then we decided that in 2013, that we would have our hospital said, we're going to open up all the notes for all the specialty practices. Psychiatry held back a little bit. So we decided our mental health notes, we held them back, but then we decided we were going to go live and we opened them up in 2014, really this month, 7 years ago. So we've had the experience of having opened up notes. And when we did this as a research project, we also decided we've always tried to partner with other health institutions around the country to open up the notes so that we, if we say, the easy criticism is, well, you're opening up notes in an academic medical center, and that's an urban part of Boston. It may not apply to my area here in, Pennsylvania or whatever, or someplace else. And so we partnered with a couple others, specifically Geisinger Health in Pennsylvania. So we had a rural group, and then we did with Harborview in Seattle, which is a core inner city population safety net hospital. And then since that time, we've partnered with many, many other networks and stuff. So we've helped basically 260 health networks to open up notes, and about a quarter of them have opened up mental health notes for many years now, actually. So I started in the social work department. My staff knew that I had done a lot of this with sharing notes, and asked all of our staff to think about whether they would open up their notes too. And I gave them an option of they could either decline if they wanted to, or they could select a certain number of patients that they wanted to kind of felt like this is a safe cohort of group patients that I can open up and see how that went, or they could open up fully. And out of the 29 therapists that I was overseeing, 25 of them chose to open up, and almost all of them fully just opened up their notes completely. Some of them did it selectively, but then ramped up, and everybody went full bore fairly quickly. There's a few folks that held back and still are nervous about it and stuff, but and that's true in all systems. Everyone is worried about, oh my gosh, is it going to be bad for patients, or disrupt the relationship or whatever and stuff. So that's how we started, basically.
That apprehension, let's touch base a little bit more about that before we actually dive into the Cures Act rule that's upcoming here in April of 2021. But that apprehension that you just mentioned, we know that sometimes clinicians are apprehensive about how to make their notes, about making their notes available for a variety of reasons. And what are some of the common reasons that you see for therapists not wanting to make those notes available, and how can they overcome those barriers?
It's a good question. So in essence, a lot of the time we've found that the anxiety is more on the clinician's part, that patients aren't as worried about stuff. And in fact, we've got some pretty good research, and we've got a fair amount of data that we've actually published on this as well, with another article that just came out yesterday and another one that's coming out next week. But it's that really shows that, in fact, actually, it's very highly beneficial to the majority of patients. There are some patients where they get more anxious about things, or they read it and stuff. And so a little of it is about marshaling expectation and setting expectation. But it especially lends itself to cognitive behavioral approaches. The clinicians that we find have the greatest hesitance about this are those that are psychodynamically trained. And I was trained in both a psychodynamic model as well as cognitive behavioral approaches. And in a psychodynamic model, you may be a step or two ahead of the patient, and you're always waiting for that kind of tip of the tongue to get there before you kind of make an interpretation. So a lot of clinicians worry that it'll be a premature interpretation on the note. There's a lot of ways to kind of put that in there in a safe way without it being problematic. And the only populations that we've had where there's consistent worry has been really, an understandable worry, is really around patients where you're dealing with someone with domestic violence or any kind of violence in some way or another. And that's part of the question a little bit with clinicians where they struggle is, who is the note intended for? So in some practices, some interdisciplinary practice in particular, the note may be intended for the eyes of the staff, but in fact, actually, patients have a right to access to the record. And they've always had they've not always had access. It's really back in the 70s is when federal legislation came forward. And actually that legislation was founded at Beth Israel Deaconess Medical Center by the then president, who wrote that. And then that became part of the template for the federal laws, but they have access. So all opening notes does, it just makes it quicker access. So some patients with a trauma history, when they read, so a lot of clinicians, when they write their notes, and I do this as well, whenever I've seen a trauma patient, and particularly say, for instance, someone that maybe is a rape crisis survivor, oftentimes you document a lot of the details about the assault or the nature of the trauma, because you're trying to validate the patient's experience. But then when that patient reads that note at home, if they're by themselves, they might not have the supports around to because it's a recapitulation of the experience. And so that becomes a little bit difficult for some of them. And so it's more about setting expectations with them about when they might read their note. And there are some patients where, in fact, I can think of several patients in my own practice, one of whom his notes were open for the whole time, but it took him 2.5 years before he read his first note. He was terrified that my note would simply, confirm his fears that he was the worst thing imaginable, So, and when he read it, it was relieving to him, but it took him a long time. That's not uncommon. So part of the whole thing about open notes is, for us as clinicians, is thinking through, who is this going to be beneficial to, and who might it be detrimental to? And is that a matter of kind of thinking through the expectations with them so that they do that in a supportive way? I'll give you one example of that. I had a patient I was seeing, I had a long-term therapy group that I was running, and all my notes were open up to all my patients, and she wanted to make sure she participated in that. So she would read her notes. The group was on a Tuesday. I dictate the note, then usually the next day, it comes back from the dictation service, I sign it. As soon as I sign it, it's then available to her to be seen. And so towards the end of the week, it would be available usually by Thursday or so for her to see. She would read the note, and then she would decompensate. She would kind of hole up in her apartment and not go out. And she just was traumatized by the note. She felt like it was saying she was a horrible person and all kinds of things. The group asked her if they could see one of her notes, because when she was telling them about this, and when they read the note, it wasn't that at all. It was a complete distortion for her. And she realized that she was distorting it. And so the group advisor, I didn't even have to do any of the work here. They said, only look at your note before you come to see your individual therapist or your group therapist, or you have good supports around, and don't read it at other times. And so she began to do that. And after a couple of years, she was able to read her notes, anytime without any problem. And that was a little bit of a harbinger of telling how she was doing in terms of her own progress in that regard. So, it's a little bit, kind of selective. I can also think about some obsessive compulsive patients that I've worked with who don't want to read the note because they tend to ruminate about things a lot. And so they don't want to just keep spinning their wheels, obsessing about something or other. So they tend not to look at it, over time. And what we found with a lot of patients is that for some, I've had some patients that they print out their note every time after every session. They'll print it out as a reminder of the work we're doing in between sessions, because they have a hard time, usually with libidinal object constancy issues or what have you, holding on to things. And so the note is there as a reminder. So it's carrying forward the therapy in between sessions. And so that's where I find it's been helpful for some. But a lot of patients also find that a lot of our notes over time are pretty redundant, quite frankly. And they are, particularly when you're seeing patients in ongoing work. They lose their effectiveness. So a lot of patients tend to only then look at them episodically every few months or every month or whatever it might be, rather than regularly. So that's been the experience so far.
Steve, I want to take a step back, but I have lots of questions. And, part of which is interesting, I think, to others is that there's been whispers about open notes, at least it seems like you've been doing this for a decade or so. And but many of us, I think, who will be listening, we heard whispers. Is this for real? What does it mean? Not be able to find much info now that it's here, and there's fear. So when I say it's here, so what I want to establish first is, can you speak a little bit more to the new legislation that's really implementing the Cures Act rules? Can you speak to that specifically? And then I'd like to ask some questions about kind of a lot of the content you discussed.
Sure, glad to. So the Cures Act was supposed to have gone into effect. First, let's step back a little bit. It was passed in 2016 under the Obama administration, and it was passed as bipartisan legislation. And it really, probably the way to think about it for anybody viewing this is that HIPAA coming of the computer age. That's really what it amounts to, is HIPAA catching up with social media and all of the computer age, right? So, and that's really in the essence of it. And it's really about interoperability. A lot of the legislation. I mean, opening notes is one component of the Cures Act, right? So that's one component. It's over, I think it's 1,400 pages or something like that, the whole bill itself. So it's a massive bill, and there's a lot of components. But it was supposed to have gone into effect last November. That got delayed till this April 5th is when it goes live. So next week, and with that, that really requires that health networks have to make available notes to patients immediately. Now, what they mean by immediately is open to interpretation, right? So we hear different networks are interpreting that differently. And there are some exceptions to what has to be opened up. Psychotherapy notes are an exception to having to be opened up. And part of that is predicated upon the fact that there is a greater expectation of privacy in psychotherapy notes than there are a lot of other health-related notes. So there is that's an exception to that. But what I'll say is that a lot of institutions and health networks that are opening up their notes, if they're opening up on the medical side, there's enough literature and research out there that many of them are just saying, we're not going to segregate the mental health notes separately. We're just going to, if we're opening up medical notes, let's just open everything up. So that's what we're finding. But places do have the option to segregate the note. And part of what we've been encouraging folks to do is to find out from their networks how those networks put in some safety concerns where they can segregate a note if it in fact is necessary. So the domestic violence, for instance, is the one area where in fact actually most of us tend to, domestic violence victims tend to get services for free rather than billed for, because just the generating the bill itself, if the subscriber happens to be the perpetrator or the alleged perpetrator, that can in itself engender greater danger to the patient. And so that is a problem. Now, we also know that some people can be strong-armed into opening up their notes. And so should those notes be segregated in some way? So most health systems are putting in ways to pull a note out of the mainstream, if you will, if there's particularly private information. We also find that that's true with adolescents, for instance, where they don't want their parent or their proxy to be able to see their note. And so the Cures Act, a lot of it is that there's heavy fines if there is what's called information blocking. So if you block notes, you can't say, I'm going to block all domestic violence patients from seeing their notes. Well, it might be that, in fact, you have to do it on a case-by-case basis. So you can't just say that, because if a domestic violence victim you're working with, if the perpetrator of the abuse is deceased or no longer in the picture, and that's a long or a moot issue, it's a long ago issue, well, that person should have access to the note if there's no clinical reason not to. If it's a current issue, then you might want to, in fact, segregate the note and keep it private. So the Cures Act allows for, if there is potential for physical harm to the patient, right? And it's interesting that they use the language of physical harm. They didn't put in like emotional harm, because a lot of clinicians are hearing it as, well, my patient's going to get upset in reading this, or someone might get upset. But there is a second exception that allows for if it's there's a privacy exception. And if there's an expectation of privacy, that note remain between the clinician of record and the patient, and not others for others' eyes, then you can segregate the note or hold it back in that way. I will also add, because the population the audience that you may have here, is that one question that we get a lot is, are private practitioners obligated to have, open up their notes in that way? And they're not if you don't have a secure platform to offer the notes in, then there is no obligation to do that at this point, because it's what's called infeasibility, right? So if it's not feasible to open up the note, then you don't have to do it because you don't have a secure platform. The law goes into effect this April for opening up notes, but there's another phase of the Cures Act that goes into effect in October of 2022 that is requiring all health networks and health insurers to provide secure apps to patients so that they can see their records in that way. So there's going to be a change where all notes will be opened up in that regard. And one of the bigger changes here is we've been opening up notes on the ambulatory side, and we have a lot of research and data on the ambulatory side where we've seen it, how effective it is with inpatient care, particularly for patient engagement and improving trust. But this is now opening up on the inpatient side, opening up notes on the inpatient side. And that's a big change. So we don't have as much research. There's some research, a little out of a couple parts of the country and some out of Great Britain, but there's not as much research on that in terms of the effects on open notes on the inpatient side.
I think what you talked about was the sense of the fear of harm, at least. And it sounds like excluded psychotherapy notes currently. Psychiatry seems like that would be more on a medical side, probably is open. Is that correct?
They are, yes, they are. And, it's interesting because in psychiatry, you can, if you're tapping just in terms of logistics, if you're tapping the mental health benefit, you might be able to make an argument that's in the psychotherapy side. But for psychopharmacologists, for instance, if you're tapping the medical benefit, particularly if it's a parity diagnosis or what have you, then you start and you're tapping that medical diagnosis, that benefit, then in fact, those notes might be obligated to be opened up and likely would be.
That's a helpful distinction. When I think about harm also from a psychotherapy perspective and weighing some of the things that you had discussed is when I think you mentioned OCD, but when I think about specific subcategories of like fear of being a pedophile and what entails in those type of exposures in detail, or in a biopsychosocial assessment where a history of drug abuse, illegal activity, felonies, prostitution, what have you, in there, and others other than a client getting access. These are concerns that come to mind. And then would can you speak to those concerns?
Yeah, glad to. So this is, where a lot of clinicians worry that in fact, what we're going to be doing is saying we're kind of abdicating all to patient autonomy and the patient decides what goes in the record or not. And we have to remind ourselves that in fact, actually, we are obligated under professional autonomy and professional integrity. We have standards that we have to meet, right? Your note is to document to not just to the patient. And the way to think about documenting a note is always think about writing your note as if your patient's sitting on your shoulder and seeing the note, right? So they're the Pinocchio of your life, if you will, right? Or the Jiminy Cricket. But you have to do it for your cross coverage, for the emergency department, for your cross coverage folks, whoever it might be, and for the insurance company if you get audited. And I know, it's less likely in private practices to get audited, but I know in our hospital, I had to oversee and deal with health insurance company audits all the time. And they're always looking to exclude paying for services because they're a business and that's how they stay in businesses, by not paying their things. So they're always looking for ways to kind of opt out in some regard. And I've lost the thread here a little bit. So it's
no worries. We're talking about, the concern about individuals with in a social biohistory or subtype of OCD that's could be very explicit with regard to fear of pedophilia or murder or things and the exposures that go along with that. And I think I heard one of your responses earlier was really about selective segregation. And when I hear about that in a way of thinking about it from a case by case perspective about protecting the client, what standards does one follow for segregation? Are there any out there? How do you process that?
That's a very good question. And I would say that, for instance, in my own staff, who were choosing to do what we call monitor and note, when I looked at the notes, most of the time they were not, they didn't need to be segregated in that way. The VA system, which opened up their notes, in their entire system, including on the inpatient side, by the way, back in 2013, they have many of their VA systems have places where they will look over a note to see what's there. And so it goes to a committee who decides whether in fact actually it needs to be monitored or not, or it's segregated in that way. And most of the time they found that very few notes actually needed to be segregated. But if you take the fears that you have that you said before, what we found is generally is talking with the patient directly about what you will or will not document, because we are obligated to do things, right? So if a patient tells me, don't tell my psychopharmacologist that I'm not taking the medications that they've been prescribing, I will usually say to them, you need to let them know that you're not doing that. And I am obligated to document that in the note, and I'm going to be communicating with them. And so it might be better if they hear from you first rather than you. So a little bit of it is a negotiation around those kinds of things about what you're going to put in or not put in. If you had somebody like the example you gave about somebody that was worried about, oh my God, am I subject to pedophilia, or am I have these urges or whatever? We usually kind of use more soft language in those kinds of ways. And the clinician may keep side notes, processed recordings or what have you, separate notes in those regard. And so you may put in, like if I'm working with someone with a history of childhood trauma, they were a sexual abuse survivor, I may just put in difficult childhood memories or difficult childhood issues or struggling with who they are as a person, things like that. I'll put in some language that any clinician seeing that would know, oh, I should ask more about that if there's a future clinician there or a covering clinician. But I may not put in the details about that because I'm, in case that I'm worried, particularly in our system where all notes are open to all other providers, right? So all the other, everybody can see the notes in the system that I'm operating in, right? So all the other clinicians, can see those notes. I would be a little bit more cryptic about those notes and soft sell it, but I would tell the patient there. What we found in our research is the biggest thing patients are looking for is concordance between what was written in the note and spoken about in the office. That's what they're looking for. And if there's not concordance, most patients, that are at the beginning of a therapeutic relationship where they're worried about, is my clinician going to understand or appreciate me? That's always the fear that's there. And so when they see that concordance, that really is helpful. The patients that we found in our research that have struggled with the relationship have been those where there isn't concordance about things. And so what you want to do is not ambush somebody. And I'll give you a classic example that we see in a lot of the notes that is pretty universal. And we see this on the medical side more than certainly on the mental health side, but we've seen it in mental health notes. And that's the documentation of someone being obese or morbidly obese. And unfortunately, for the medical side, the docs or nurses don't get reimbursed if they don't put in their note, patient is morbidly obese or dealing with morbid obesity in the note, because the ICD-10, doesn't, if you don't put it in that note, you don't get reimbursed. And so there's a lot of pejorative language that comes out of the fact that we do notes that are really for billing purposes in that way. And we're obligated to put down a mental illness diagnosis. If you're billing for psychotherapy, you're obligated, if you're using a health insurance plan, to put down a mental illness diagnosis. You can't put down a V code or an S code. You won't get reimbursed. And so explaining that to patients is really important. And that's also tricky when you're doing a provisional diagnosis or a differential diagnosis in the beginning, and just saying to them, I have to cover the gamut. Those are my obligations. So it's really just not ambushing patients.
Steve, I want to go back to, you talked about having the discussion, negotiation about the notes. What popped to mind is on the medical side, as well as the psychotherapy side, can you omit when someone reports a particular symptom or a concern? I would imagine if a lab came up, anemia, just say in medical, you couldn't just admit that. And so my concern comes up is that if there's a concern about drug use and it comes up in the assessment, it's probably good for that clinician to have that, remember that for down the road or some other purposes. Yeah. Is it ethically or legally appropriate to omit? Or are there things not to omit? And what are the standards for which psychotherapists can follow so that we can make sure we're doing what's best for the client, but also staying within ethical and legal bounds?
Yeah, it's a great question. And it's what I would say is that you really want to you do the note that meets your professional standards at all times, that we are obligated to do differential diagnosis and to kind of put in what is going on with the person in some regard, a symptom picture. But it's very tricky about how much detail. And that's really more on a case-by-case basis. It's kind of thinking about the old DSM. When I was dealing with insurance companies and dealing with coverage, we used the GAF scores, right? The Global Assessment of Function scores, as the best argument for particularly for patients that are ongoing therapy patients, where in fact there isn't a lot of movement, but as a clinician that if this person stops therapy, they were going to regress in some regard. And that's usually what you have to do is the argument. And you think about it in terms of the GAF score, that was the best argument for that. So we would usually document around GAF scores more than anything else about what the potential was for the decline in that regard, if the person were to terminate therapy or stop therapy in some regard. And that was probably the most helpful thing for us in terms of bridging when we got audited by insurance companies for that. So that's a kind of an obligation. But in terms of what you put in the note itself, the lurid detail, that's going to be on a case-by-case basis. And so I can think of, patients that I worked with that had a high lethality level. My notes were much more detailed about that. So I'll give you an example. So I worked with a lot of patients with a borderline personality, and I worked with a lot of cutters. But I would try to make sure in my notes, particularly because my cutters would come in to the emergency room sometimes, that they would, their notes, I had to distinguish between when they were suicidal versus when the cutting was really a self-soothing mechanism, right? So cutting for most patients, cutters, That's usually an anxiety relieving thing as opposed to when they were suicidal. So I would put in some pretty good graphic detail about ways for clinicians to distinguish that. But that's partly because I'm needing to do that in a cross coverage system for patients of mine that ended up coming into the emergency room pretty regularly. So I would put in a lot of detail. A little bit is going to be case by case basis, unfortunately. So it's hard to give good guidance in that.
Understood.
If I put on a legal hat in that way, it's usually we're held to the standard of what the reasonably prudent therapist or clinician would write. What would be the reasonably prudent clinician? That's usually the standard in most states, that I would say is. How would your colleagues view this? No.
I'm sure that could be a whole series of podcasts for us to look at. I think a good way to kind of, as we begin to close, is talk about, I could see how open notes, based upon Scott Miller's work about informed patient care as a feedback and the improvement that gets, and how open notes would be helpful. Could you speak to a little bit more about the research? Is it specific to psychotherapy modalities? Is it attachment? Is it CBT? Is it some other methods? What have you found in the literature you've read and seen that you spoke of?
Sure, glad to. So I would say the majority of what we're seeing, and this is true around the country, I would say CBT is the predominant mode of therapy across the country, really, in for the most part. But we've seen its applicability in all modalities now. So we've seen it across the board, and we've got, I think, enough experience. So, if we think about before the Cures Act is going into effect, as of this past winter, we had 55 million patients that were in the Open Notes program, right, across the country. So we're participating in that, and about a quarter of them are those systems that have mental health notes that have opened up. And you would think that, in fact, actually, if there was a lot of difficulty with this, you would have been hearing it across the country as places have opened up. And it's really been remarkably quiet in that regard. So I think it's really what we've seen is that it's helped our literature and all the literature, particularly Steve Dobsha at the VA has published some wonderful literature in psychiatry journals, as have we actually. It really shows that it's really been effective across the board with a variety of different populations. What we haven't done big studies of major mental illness. We have a couple embarked on that right now. There's some groups that are doing that, particularly up in the Toronto area. The Center for Addiction and Mental Health up there is doing that. They've opened up, I think it's 1,100 inpatient substance use and psychiatric inpatient beds. Are open notes for a while now, and I think it's 1,000 or 1,100 outpatient therapists, and they're studying that. And there's other places. University of Colorado is doing this as well. So there's a lot of studies going on about different populations to see the effect of that, and most of it is we're finding it very helpful. I will add, there's one other thing that we're embarking on called our notes. And our notes is, if you think about this on this psychopharm side, particularly with stable patients or patients who are in ongoing psychopharm seen periodically, we're asking them two questions. Has anything happened to your health since your last visit? That's one question. And that would be good to know about. And so the docs and nurses can tee up labs or other kinds of things if there's something. You think particularly in the medical side, but we're thinking about it on the mental health side too. And then the second question is there anything you want to make sure you attend to or address that we should address in your upcoming visit, in your next upcoming visit? And we limit the number of characters on that. So our obsessive compulsives can't write 50-page tomes. It's a limited character thing. But that becomes a permanent part of the record. As well. And we're thinking that may actually be a really good thing for pharmacology in particular, to be able to kind of address things ahead of time rather than waiting for the patient to get to the office. And now you order labs, you could order them ahead of time if you needed to do that, if something was cooking. So I
look forward to seeing, Steve, what happens as a result of that. One final question, because you talked about the research being helpful and effective. Can you conceptualize for me what was effective and helpful? What was being measured?
So we measured, we were measuring basically a couple of different things, we measured after 1 year of people being on open notes, right? Both the patients and also the providers. We measured their fears, their anxieties to begin with, whether it was more labor, and they were all worried about it being more labor intensive. It would be more problematic, all that stuff, all those fears were there. And then a year later, we measured it again. And we basically found that all the fears did not materialize. Most of my staff found that they started writing better, more cogent notes, more concise notes. I can think of one of my staff people who was writing a progress note that was taking her 23 to 25 minutes per time. And she got back down to the average of most of my staff was 7 to 9 minutes to write a progress note. And so she was writing too many details. And so they've become more efficient in that way. So we studied that and measured that. And then we studied, at the end of the year, did patients want to continue? And did providers, therapists want to continue? And they all did. And we found that across the board in all the other systems. So that's been there. And we tried to find out, is there any kind of untoward outcomes, anything that they've learned from it? And that's why I kind of mentioned before about, we know from, particularly from the VA studies, about patients with trauma, when they read the note, it's a recapitulation. And so we have to think about some populations where it could be a little bit problematic. But by and large, and I would say in our practice, we started with 440 patients. We've now got over 5,000 patients that we've studied. And we're not seeing the issues there. So it's been really it's been a nice thing to add on to the toolkit for clinicians. And again, it works for some, and it's helpful for some, and helpful for probably most. And it's not so helpful for some others. It's just so necessary.
This has been very insightful and timely and fascinating conversation. I really appreciate you coming out, Steve, and talking to us. I think very good timing, and I think a lot of people would be very interested in our conversation today.
Great. Well, thank you for inviting me. Appreciate it.
And Steve, before we wrap up, could you share with our listeners where they can find information online about Open Notes?
Great. Thank you, Erin, for that question. So, because, a lot of times folks think that we in the Open Notes program, that we're selling a product or something. We're not. We are purely, quite frankly, a public service. We believe in transparency as part of healthcare. And particularly if you think of, you think about it with the COVID, stuff about the distrust in some populations, and that the more we can open up and be transparent, we think it's an avenue to restoring trust in healthcare. And so that's all we've been working on for all these years, is really trying to make it grease the skid. So we're supported by various philanthropies, and all of what we do. On our website, we have a mental health toolkit, we have Q&As, we have literature, we have all the research. All of that is there for anybody to utilize in any way they want. We don't charge anything. There's nothing there. It's a free service that we just, you can take and you can adopt whatever we put out there to your own needs. In that way, you can plagiarize what's in our system, and that's fine by us. That's really what we have. It's there to be just as a public service and a public good in that way. So that's, and it's on the Open Notes website, all of this stuff.
And what is the web address?
It is just opennotes.com, or it is what it is. So that's all it is, www.opennotes.com.
Easy to remember. That works.
Great.
All right, wonderful. Well, thank you so much for being with us. I think, as Kevin indicated, we could spend hours, dissecting multiple parts of this. So it is very helpful, and we really, really hope to stay in touch with you. And I know as things in October of 2022 take a change, I'm sure we'd be honored to have you back to discuss further how those changes will affect private practices. So thank you so much for everyone for listening to this week's episode of The Barrier Breakdown. Stay safe and healthy. Take care.
Thank you for listening to The Barrier Breakdown, Disrupting Mental Health. Listeners can find all of our episodes on YouTube, Apple Podcasts, Spotify, and Podbean. For more information and to learn about upcoming continuing education events, check out our website, cbicenterforeducation.com, our Facebook pages, Cognitive Behavior Institute and CBI Center for Education, as well as our Instagram at Cognitive Behavior Institute and our Twitter at CBI_Pittsburgh. Don't forget to like, comment, and subscribe. We hope you'll tune in for another guest next week.